All right, is everyone ready to begin? I hope so. We have 2 more class sessions. You may be thinking to yourself, wow, Dr. Wood, you're really poorly pacing this class here. You're behind schedule, and that is true, mainly due to the fact that normally we have, at least last year, we were able to have the test outside of the class time. That was a recent change, and so I'm trying to still adapt the class to deal with that decreased time. That's basically 2 hours missing out of the class because of that, and so that's a whole lecture period essentially. So that is the difficulty why we're a little bit behind, but also why we're going to continue forward and try to knock out what we can. Okay, I cannot guarantee there might not be a small video you'll have to watch on your own that I will record and then post up. Just FYI, but it'll be we'll have to play that by ear. Okay. Any questions before I get started? I know that's going to be all in all of my reviews. He made me watch stuff outside of class, but it is what it is, right? Anywho, pediatrics. We talked about the Jerrys. We talked about the elderly. Now let's getting into some of the changes with pediatrics. Why is peds so hard? Who wants to go into peds? Okay, you want to go into peds? Just the one? Wow. Why did the rest of you do not want to go into peds? Kid? What's my wrong kids? Their parent? Yes, that is a much more legitimate answer than the kid. The kids are awesome. The parents sometimes not so much. But regardless, huh? That is true. They do a lot more stuff in your face too. They'll spit medicine at you and wipe the boogers on you, and that's terrible. But regardless, they are an at-risk population. The reason for that is because they're very heterogeneous compared to an adult, right? Dealing with a 20-year-old versus a 30 versus a 40-year-old adult is roughly the same versus dealing with someone who's 1 day old versus 1 month old versus 1 year old, right? They change very rapidly, and so it's important to look at how those changes are affecting how the drugs are working, how the body's handling the drugs, and so that's what we're going to kind of dive into on this group here. And again, one of the things you're going to find, you may be seeing this in some of your homework assignments, some of your drugs, is say, well, not for use in children, right? The reason for that is because they're not technically approved by the FDA for use in kids. And why do you think that's the case? It is very difficult to do testing in children, especially neonates, right? Because again, they're a very at-risk population. It's not necessarily ethical to say, well, I'm going to give this 50 babies, this drug, and these 50 babies control, and we're going to see what happens. You can't really do those type of studies. So a lot of what we have is being extrapolated back from adults to children. It may be one-to-one. A lot of times it may not be, and so that's some of the difficulty. Even though it says we may not use this drug for kids less than 2 or less than 12, I guarantee you a lot of them we still do use in very young children, right? So again, we are sometimes using, that extrapolated data. Sometimes we're using our best guesses to see how these drugs are going to work in these kids here, right? Sometimes it's anecdotal evidence we're using there. Anywho, so our lingo here for pediatrics. So basically the gestational age is what? Anyone have heard this term before? How long the bun cooked in the oven, right? So again, how long were they developing in the mom? And we'll look at normal gestational ages here in a second. Typically based on the last menstrual period, but also based on physical exam, based on ultrasound, measuring the baby, you can kind of get a general idea for how far along that child is. Postnatal age would be their chronological age after they are born. So if you're born today, tomorrow you're going to be 1 day old, etc. And then post-conceptional is the two together. The reason why we focus on these two, and this is particularly important for the neonatal period, which we'll define what that is in a second, but a lot of drugs tend to get dosed based off of the gestational age of the child, the postnatal age of the child, or it could be a combination of the two. You might have to look at both of those to determine how you're going to dose that drug. And we'll look at the factors that go into that. You don't use post-conceptional age too frequently, but it's just to know, those are the two put together. For a preterm infant, we will say they are less than 37 weeks gestational age. How early is the earliest you could still reasonably sustain life? Anyone know? Kind of think like 24. We've had like 22 weekers that are very, very fragile, very difficult to manage. They're usually in the NICU for usually the better part of a year in some cases because they are so difficult to manage because, again, they still need a lot of time to develop there. But, yeah, 24 weeks is pretty young. Full term would be that 37 to 42 period there, right? So that would be a fully developed full-term infant. Post-term is anything greater than 43 weeks. Now, you may hear the nomenclature kind of used imprecisely, but you'll see that the newborn or the neonatal period is technically that first 28 days of life. So that first month of life is considered to be the newborn neonatal period. Does that mean if you're in the NICU, the neonatal intensive care unit, they kick you out the day you're 29 days old? No, sometimes you'll see kids that are in there for several months, right? So that's not uncommon to see that. For that first year of life, though, you may hear kind of all of them referred to as infants. So, but if you hear infant, you're thinking the first year of life. If you're neonate or newborn specifically, it's that first month you're referring to, okay? Toddlers are usually that 1 to 2 year age range, young child 2 to 5, older child's adolescents. Now, when do you think we start to treat some of these patients more like their adult counterparts? Yeah, so you're around the adolescent period, right? So once they're in their teenage years, typically they are fairly well developed in terms of the kinetics. We'll see how that develops in just a little bit. But we'll see that they are also starting to get close to adult weights, right? And so how do we dose a lot of medications for pediatrics? We do a lot of weight-based dosing, right? So again, one of the big caveats you're going to see with this is if you're using weight-based dosing for a child, if you start to get close to or over the adult dose, you cap out at the adult dose, right? So again, if for instance the drug roseftriaxone, it's an antibiotic we're going to use pretty frequently in the hospital, you see that the dose is say 50 milligrams per kilogram. Well, once with a max of 2 grams. For a child, once you get up to that 2 gram mark, you're not going to go over that, right? Because again, you wouldn't use more than adult doses for that child just because they're large. And again, sometimes you can see some very large children. Why would we see large children? We're in America. That's one way to put a cap on it. But yes, we have a lot of childhood obesity. But also think about the fact that like we at Nemours, we have a contract with Disney, right? So anytime a kid gets sick or injured at Disney, they come over to us. So we have a lot of like sports festivals and stuff that go on, right? So every summer we get a lot of like football players that are coming in. So you have these like 16-year-olds that are like 240 coming in, and the broken femur, right? We're not going to dose them higher than you would an adult patient because again, they are basically adults at that point. Okay, so just one of the other caveats you're going to see with the dosing here. So looking at this, we're going to dive into the kinetic changes that occur for these patients. You're going to find that first month of life is typically where you see the greatest changes, and then over the first couple of years or so, they start to slow down into young children's and eventually into adolescence. Really, they're just kind of growing at that point and just getting bigger. You're going to see that for some things, they may actually level out to adult levels within, say, the first couple of years of life. Some things take a little bit longer to develop, and we'll look into those different features there in terms of their kinetics, right? So looking at the absorption of drugs, the same principles apply to adults as they do to children here in terms of how things get absorbed. We're just going to look at the actual physiochemical differences in those children to see how things change. So looking at things like molecular weight and particle size, what do you think gets absorbed better, bigger or smaller weights and particle sizes? Smaller, right? Smaller gets in easier through those little holes there. pH and pKa, we'll dive into why that is important. We'll look at some of the changes that occur, but again, you can't just throw out stuff just because you had it on the last task. You got to remember all those changes, like dissolves, like I remember the Henderson-Hasselbalch, all that fun stuff. And then we'll also look at the dosage forms, right? So for adults, what's kind of the most common oral dosage form you'd administer? Tablet, capsule, something like that. What about for children? A lot of liquids, right? A lot of them are not able to tolerate oral or solid dosage forms, and so we will have to use things like liquids in a lot of cases there, right? And so you have to think about, well, what is that drug being formulated with to put it into a liquid? It could be alcohol, it could be sugar, it could be a lot of different things in there that could be affecting the patient. So we'll get into some of those details as well. But also looking at the site of absorption, right? So the skin of an infant is much different than the skin of an adult, and that can have big effects on drug absorption, as we'll see. So gastric absorption, first off, 2 main determinants here are going to be your gastric acidity and then also the emptying time. Okay, gastric emptying time kind of refers to what? How quickly things are moving through the entirety of the GI tract, right? So if you had to imagine for, say, an infant versus an adult, which one do you think would be faster? Infants typically are faster, right? If you think about babies and how often they poop, it kind of gives you, it'll illustrate that. How often do infants poop? Does anyone know? Too much is the perfect answer for that. It could be like 6-8 times a day in some cases there, right? Versus when you get to like more than an adult, it could be like 1-2 times a day, hopefully, right? Some adults you may find once a week on a good week, right? But the point is that the GIT is going to be a lot faster for those patients, and we'll look at how that affects absorption, okay? Greatly differs between infants and adults. Looking at the pH-dependent passive diffusion, we're going to see that in terms of the gastric pH, especially the more premature the infant is, the higher the pH is going to be. Within the first couple of days or so, you're actually going to find the gastric pH, which is, what is normally the gastric pH? Gastric pH. Should be like 2 to 3, right? Should be pretty acidic, okay? Well, it's going to be a lot higher than that, usually like 6 to 8 or so for the first couple of days. And why is that? Well, the babies have been kind of passively just kind of swallowing some of that amniotic fluid, and that is fairly neutral, right? So, yes, sir. Yeah, so normally you'd find gastric pH to be, say, around 2, right? For the first couple of days of life, you're going to find for these infants that it'll be around 6 to 8, and that's mainly because their acid production has not really kicked in yet, because again, they haven't been eating anything for that 9 months, but that amniotic fluid that they're surrounded in has, kind of passively swallowed some, and that is what's filling up the GI tract, so that neutralizes a lot of those acids initially. The first couple of days, you're going to find that can affect drug absorption via the oral route, right? So weak acids, for that first few days, they have a harder time or an easier time getting absorbed from the stomach. Have a harder time, right? Because it's in a more basic medium, it's going to be more charged, it's going to have a harder time getting across, okay? Also, looking at the more immature the infant is, the younger they are in terms of gestational age, the longer it's going to take for their acid production to actually kick in, right? Because again, when you're born at 24 weeks, it's not like all of a sudden everything just starts working normally, right? You're still very immature from that standpoint, and the body was not ready to start producing that acid yet. You weren't ready for oral absorption of food and drugs and whatnot. So that's a main thing to focus on there. Usually you'll find kind of a big spike in acid production around the first 10 days or so, and then usually by 3 months they're around adult limits, right? So that's kind of the biggest thing you're going to see. The first few months is when oral absorption may be affected by that, okay? Basically for acidic drugs, you're going to see they're going to have a little bit harder time getting absorbed. For basic drugs, they'll have an easier time. So gastrointestinal emptying time is, again, that factor of how fast things are moving from the GI tract. Now, quicker times, meaning things are moving through more quickly, what do you think it does to drug absorption? Increase it or decrease it? Why would it decrease it? Yeah, less contact time with the gastrointestinal tract, right? So again, the less time it has actually contact with the absorptive surfaces, you're going to find it's less time for it to be absorbed there. So that is an important feature. You're going to find that this can be affected though. So for instance, if you have a kid with a congenital heart defect, they may have an issue where they're not delivering enough oxygen-rich blood to the GI tract, and guess what that does to it? Speed it up or slow it down? Slows it down, right? It's not getting enough oxygen, it's not producing enough ATP, it's going to slow things down. And so that can be important. Type of feeding, whether they're breastfed or formula fed, can be an issue there. And of course, gestational age is going to be a factor here. So the younger they are in terms of maturity, being born in gestational age, slower it's going to be in a lot of cases. So, as I mentioned, shorter transit time, or the more quickly things are moving through, means less contact time, less absorption is going to happen there. That's why you don't see a lot of like extended release preparations being used for infants, right? For adults, we can give a drug that slowly releases over the course of 24 hours, but that's a lot faster for an infant, so we don't use a lot of drugs like that. And that also may account for if you have two different, neonates that are roughly the same size, you can give them the same dose of drug, but you may find serum concentrations would be different between the two, and it could be a result of the gastrointestinal emptying time, right? You have one kid who has a congenital heart defect versus one that doesn't, you may find that one has lower levels than the other, okay? So little things to consider. So other extra oral drug absorption, so getting it more into the parenteral routes here. So things like mucosal blood, or muscular blood flow, mucosal permeability, and then skin permeability. It's not just parenteral, but also transdermal here. Typically, you're going to find, and we'll get into each of these individually, but we're going to find alterations in all three of these to where they can either increase or decrease the absorption of these medications, or at least the speed at which they're being absorbed here. So refer back to this when you're kind of studying the stuff. Looking at intramuscular absorption, you're going to find this is going to be dependent on several factors. One of which is that you need to have blood flow to the area to actually have the drugs actually being absorbed there. And you're going to find that it can also be a factor of how well the drugs can actually penetrate through the capillaries. But one factor we're going to see here is that volume of distribution for these kids is much different than adult patients, right? Especially in that first month of life or so. And I'll get back to this, but essentially they're a big bag of water. You can kind of think of infants as a giant bag of water. They have a lot more body water as compared to more adult or older patients. What do you think it does to volume distribution for hydrophilic drugs? It's going to increase it, right? So again, you're going to find that typically these young children are going to have a much higher volume of distribution for a lot of these drugs, and that can affect how well the drugs get absorbed from the intramuscular route here. Not only that, but if you think about a neonate, do you think about neonates as like being really active and getting around, rolling around, getting up, walking around? No, they're pretty stationary. They're just kind of like little blobs that just kind of sit there for the most part. Usually they're papoosed up and you're just kind of chilling. That means they don't have a lot of blood flow to the muscles because they're not really moving around a whole lot. So that can decrease the rate of absorption of those drugs there. The bioavailability might still be pretty good because, you put it right there in the muscle. However, you may find that the absorption rate is slowed, right? It may not kick in quite so quickly. Also, I mentioned that percent body water is going to be much higher, so there's more water in the muscles there, which can affect the volume, the distribution. And then also, as I mentioned, due to decreased muscle contractions, they may not be, again, having that kind of penetration that you're looking for there. Another big feature we find is that also they have this peripheral vasomotor instability. And again, when you think about little babies, like you normally got to wrap them up, right? Why is that? They get cold, right? Because again, they can't really regulate their temperature that well. And so because of that, that also can affect blood flow to the muscles. That can affect the drug absorption there, right? You guys ever heard of neonatal abstinence syndrome? What do you think that sounds like? Neonatal abstinence syndrome. What do you think that would refer to? Abstinence from what, do you think? Actually, abstinence from drugs, right? So again, you'll have these moms who maybe have been exposed to cocaine, heroin, all these different types of medications. They are physically dependent on those substances, and then the baby's born. But guess what? The baby's been exposed to that stuff the entire 9-10 months of that pregnancy. So what happens to that baby when they come out? Right. They're now abstaining from that medication, and guess what? They start to withdraw. That is a big feature we've seen in a lot of kids, especially at Nemours, where we don't have the babies being born there. We transfer them in, so we normally get a little bit sicker population there. We find a lot of kids with neonatal abstinence syndrome. It's really tough because, again, they are actively withdrawing. If you ever see an adult patient withdrawing, you're going to know how uncomfortable and miserable that is. Imagine that for a baby. And then also it can affect a lot of things like their feeding. It can affect things like their vasomotor stability and the fact that they can't regulate their temperatures very well. A lot of different features that go into it, and it's really tough. How do you think we treat that? Yeah, put them on the medication. Yeah, potentially, right? So, for instance, if they were withdrawing from opioids, we can actually put them on methadone, right? So you'll see little baby doses of methadone. There's some other drugs we use as well, which we can get into later. But just, again, think about the different clinical situations you might be running into. It's a sad thing, but it's unfortunately very common thing in a lot of cases you may have to be dealing with.
Does that also apply to mothers with drinking during pregnancy?
100%, yeah. So again, just like you get physically dependent on having that alcohol effect around, or it could even be like, anti-anxiety drugs like benzodiazepines, like alprazolam or Xanax. Same thing can happen there, right? Even mothers who deal with postpartum or intrapartum depression, they're on antidepressant medications that whole time. Guess what? Babies can still withdraw from that stuff too, right? So it can be any medication. It doesn't have to be illicit substances. It could be things that are being prescribed through a normal therapeutic course of action. So it's a very interesting subject, but we'll cover that later.
Also prescribed knowing that the baby is gonna.
Yeah, because again, if you have a mom who is potentially suicidal without antidepressants, then obviously if the mom's not going to survive, the baby's not either. So it can be a really tough situation for sure. Anyway, not to again, I get off my own tangents a lot of times, but it's okay. Getting to rectal absorption, you're going to find that typically the rectum is very highly vascularized. Also, the mucosal permeability is very good. It's a fairly thin membrane. Remember that fixed law we talked about? Thinner the membrane, more vascular the area is, the better absorption you're going to get with that. That's why we use a lot of rectal medications here, right? Because especially if the GI tract may be not good from the oral route, we can use the rectal route and get some good absorption there. Frequently, we use things like rectal Tylenol or acetaminophen. That's probably the most common thing you're going to see being used for fevers and teething pain and things like that. However, you have to consider they have an increased amplitude of rectal contraction. So what do you think that would do for us? They spit it right back out after you put the suppository in. Is it going to work too well? No, the drug has to have time to actually melt and get absorbed and all that kind of stuff. So how do you deal with that? You get a little C-clamp and just kind of tighten it around their little cheeks. And I'm just kidding. You just hold their cheeks shut for a couple minutes, and then that allows time for the natural heat of the body to melt the suppository, and then it can absorb, right? So again, little things you have to think about, because again, you may have a parent who says like, man, this Tylenol's not just working, and then they realize that they'll put the suppository and put the diaper on, and then they'll go back later and realize that like, what's this gooey mess in the diaper? Well, it's because they spit it right back out. Not spitting technically, but they will expel it right back out, and the drug never had time to absorb, right? So again, little things to consider there. Well, looking at intravenous administration of these drugs, we mentioned intravenous bioavailability is always 100%, but what are some of the difficulties of using drugs intravenously for a child? It can be really difficult to get a good vein, right? They're very tiny, they're very delicate. Imagine if you had, say, a 1-week-old coming in, maybe only weighs 1 or 2 kilograms coming in, and they are actively coding, right? They're in cardiac arrest. They're not perfusing. How easy do you think it is to get an IV for those kids? You're not going to, right? You have some expert nurses who are able to do it, but like in a lot of cases, you're not going to have the ability to do that. So how do we get around that? Well, we have that intraosseous absorption that we mentioned before. You can use what we call an IO, or intraosseous needle. Usually they have an Easy IO is the common brand name you're going to see out there. And basically they will be able to put that medicine right into the marrow, and you're going to be able to put fluids in there. You can put epinephrine in there. You can put whatever you need to right there, and it will be absorbed very easily, which is the nice thing. So there is always a way to get around that. And frequently you'll see this if you work in ERs and you see, say a baby coming in, very frequently EMS has already put one in because they needed to administer drugs potentially, right? Looking at percutaneous absorption, or through the skin, we mentioned that the infant skin, thinner or thicker than an adult? A lot thinner, right? So what does that do for drug absorption? Increases it pretty greatly, right? And this is a problem in some cases. This is why certain drugs cannot be used topically on infants. This is why we have to avoid certain substances, because we see some issues here. So as an example, using iodine, like in the antiseptic called betadine. Betadine usually kills off bacteria and things like that, but it contains iodine. What is iodine used for in the body in terms of hormones? Produce a thyroid hormone, okay? So you need iodine around to actually produce thyroid hormone, but actually what you find if you have too much of it around, it actually can suppress the thyroid gland as well. So that can actually lead to hypothyroidism, because these kids are able to absorb that iodine through their skin, right? One thing. Also, their skin is very well hydrated, so that also helps increase perfusion, helps increase absorption. Also, their body surface area, they have a lot more body surface area for their weight compared to an adult patient, which means that even applying a small area, drug to a small area, they can still have pretty significant absorption there. Other cases where we've seen issues. Imagine if you're using isopropyl used to be used to help kind of cool down babies and clean them off, but they actually found that they could absorb isopropyl alcohol, right? What is isopropyl alcohol? What's another name for it? The rubbing alcohol. They absorb that, and does that make you drunk just like ethanol does? Yeah, any alcohol can make you drunk, right? So isopropyl alcohol would actually get absorbed. They would have this ultramental status, which is hard to detect in an infant. However, the hypoglycemia they were experiencing was quite real, and that was a problem, right? Because again, you can see seizures, coma, death if you don't have enough blood sugar around to supply for your brain. Other things, like antihistamine lotions, like Benadryl lotion, they were able to absorb that and cause anticholinergic toxicity, which we'll get into much later. But again, you can see a lot of effects from this. And it's mainly just due to the fact that they are very well perfused, and it is very thin skin that you're dealing with there. Now, looking at distribution for these kids, you're going to find, remember that volume distribution is equal to that C0, or I'm sorry, dose over C0, right? So again, looking at the dose, looking at the concentration we're getting is going to help us to determine what that VD is going to be. Now, one thing you're going to find with volume distribution is it will change pretty greatly as the kid gets older, and this is going to be a feature of looking at their distribution sites here. Looking at this picture, you're going to find that total body water is going to be this blue line here. You're going to find the extracellular water is going to be red, and then the body fat is going to be in this green. Now, again, when you see like a little baby being born, you always think about like baby fat and things like that. Typically, though, they have less body fat when they're first born versus several months to say like a year later. However, they still have all those rolls and they're all chubby, and a lot of it's due to actually water, right? And so you're going to typically find that they have a lot of increased body water, and that will affect the volume distribution for hydrophilic and lipophilic meds, right? For hydrophilic meds, this should be higher or lower. It should be higher. For lipophilic meds, it tends to be a little bit lower, right? So again, that will affect, and I'll just show you some actual clinical examples of where that comes into play here. But again, you're going to see by 3, 6, 9 months to a year, typically it's going to be closer to adult levels, okay? All right. As I mentioned, other things that affect this include things like plasma protein binding, tissue protein binding, right? Tissue protein binding normally does what to the volume distribution? It would actually increase, right? Because again, it's holding it out into the tissue versus in the blood. And again, different states can affect this pretty significantly, right? So if you have edema due to fluid overload, that can affect the volume distribution. If you have burns and you're dehydrated, that can affect it as well. So a lot of different things can have change this. The important thing to note, though, is that for the newborn infant, you actually find that about 70 to 75% of their body weight is actually water, as compared to, say, like maybe 0.6 liters per kilogram for an adult. It's much higher for these patients here. You're also going to find they have a lot more extracellular water component than adults as well. Less fat tissue, less muscle tissue, and thus that means a much increased volume distribution for those hydrophilic meds. Okay. And what's interesting though is that normally what do you see with the weight of an infant as soon as they're born? actually drops pretty significantly, right? They actually diurese a lot of that extra water they have left over from mom. And interesting, I don't know if it's interesting or not, but just to kind of give you, an example how this happened. Normally after you get discharged from the hospital, you go back to your pediatrician in the first couple of days or so, have the baby checked out, make sure everything looks good and whatnot. For my second child, she's actually born on December 20th, so we were obviously concerned with offices being closed for Christmas, right? So we're like, okay, let's go ahead and just try to get her in as soon as we can. We try to get discharged as fast as we can. And so sure enough, they're looking at the weight. They're like, oh, I don't know, the weight's kind of dropped a little bit. She hasn't really put much weight back on because she's like 2 or 3 days old. They're like, oh, okay, let's bring her back again just to be safe, right? Not realizing that, okay, well, the kid's eating just fine, like they're going to put the weight back on. And sure enough, it came back right after Christmas, and they're like, oh yeah, she's like well above, she's like in the 80th percentile for her weight, or for her age, like she's totally fine, right? But again, they lose that weight initially because a lot of it's diuresis, and then they'll put it back on normally, okay? Anyway, but looking at how that factors in for the volume distribution for these medicines, essentially, a baby is going to have a much higher bucket, a much larger bucket to fill with that medication than the adult might, right? Again, I don't recommend putting your children into buckets, however hilarious and cute it might be. Again, that can tip that over very easily. When you have a head injury to worry about, it's not good, right? Anywho, but the point is illustrated that they have a much larger bucket you're trying to fill with those meds. How does that actually factor into clinical practice? Well, looking at the drug gentamicin, anyone know what gentamicin is? It's an antibiotic. Yeah, we use it very frequently in the neonatal period for potential sepsis and things like that. Gentamicin is very water soluble. It's a very low volume of distribution in adult patients, right? And you can see that if you're looking at the volume of distribution for adolescents and adults, 0.2 to 0.3. What do we say is a cutoff for having a high volume of distribution? 1 liter per kilogram, right? So for these neonates, you can see here, it's roughly 2 to 3 times as high as the adult patients, right? So what does that mean in terms of the dose we have to administer? We have to give a larger dose to get the same serum levels, right?
Because the bucket is larger.
Exactly, right. So remember, C0 equals dose over VD. So to get the same C0, if my VD's gone up, what do I also have to increase? The dose, right, to keep everything proportional. And that makes sense when you actually look at this. Looking at the adult and adolescent dose, say for instance you're only giving 1 to 2 milligrams per kilogram to get a certain serum concentration to kill all those bacteria. To get the same serum concentrations for a neonate, I'd have to give 4 to 5 milligrams per kilo. I'm trying to fill that larger bucket up with more drug to get the same serum concentration. That make sense? Okay, so again, this is a feature of the volume distribution. It has nothing to do with how they clear the drug or anything like that. It just has to do with how big of a bucket we need to fill up with drug. Okay, kids have that larger bucket based on their size. And this is, again, mainly for hydrophilic medications you're going to see this with. Okay, so again, bigger dose on a milligram per kilo scale than the adults would because they have a higher volume distribution. These have to be kept proportionally higher to keep that C0 the same.
So you're saying for lipophilic meds it's not the case?
Right, so for like a more lipophilic medication, you might have to give less drug because they would have a lower volume distribution. Yep. And again, when you're doing this clinically, when you're actually looking this stuff up and you're dosing it for your patients, you're not going to necessarily be thinking about, okay, what's the actual volume distribution for this child versus this child. However, when you're looking this stuff up in your dosing references, right, so if you go to LexiComp and you're looking up the dosing for gentamicin, it'll tell you, okay, for a kid within the first month of life, here's how you dose it. When they're older than that, when they get into, say, the normal pediatric period, here's how you dose it. Those changes in the dosing, which you should be observant of, is having to do with the volume distribution changes and the other kinetic changes that happen there, okay? So again, while you may not think of it in the forefront of your mind, hopefully subconsciously, I'll still be there forever saying, like, hey, remember that? That's why that changes there. That's why these things are different, right? I have a lot of PTSD from my classes there, so I'll probably be sticking with you for a while, unfortunately. And there's always YouTube. You always go back to me whenever you want. Forever and ever. Okay. Anywho, other features here. Decreased plasma proteins, right? Typically, we mentioned they have less muscle mass. It also has to do with their serum proteins as well. Typically a little bit lower, meaning they don't have as much protein binding stores, right? So free fractions of medications may be higher. And also we have to worry about things like displacement of other products, right? So for instance, albumin likes to bind to bilirubin, okay? Have you guys ever heard of like neonatal jaundice, right? Normally jaundice turns to what color? Yellow. Turns to yellow, right? So we actually, in some medications, we cannot use in that first month of life because it actually displaces bilirubin off of the protein and can induce jaundice for a child. So for instance, that drug Rocephin or ceftriaxone, it's a very good antibiotic, but we cannot use in that first month of life because it'll kick all that bilirubin off and then the kid will get jaundice, right? We don't want to do that. So instead, we can use alternative medications for that first month, and then when presumably their bilirubin levels have gone down because they metabolized and got rid of it, then you can use that other medication again. Okay. So again, this is a feature of why certain drugs cannot be used during certain periods. It could be due to some of these kinetic interactions here. Okay. Other drugs like phenytoin, which is an anti-epileptic or anti-seizure medication, will have higher free fractions of the drug because they have less protein to bind to, which means that even though they may look like they have a therapeutic level, it could be that they're experiencing toxicity because that free fraction is higher. Okay, and we'll go into more detail on that in the therapeutic drug monitoring section in a little bit. But looking at their proteins here, it's not going to be consistent amongst all of them. You may find some are going to be increased in some cases here, some are going to be lowered. It just depends. Again, don't memorize this whole slide here, but just know what those changes mean in terms of how that might affect the kinetics of the drug. Okay, so if I tell you on a test question, hey, this neonate has lower albumin levels, what does that do to the free fraction of a highly protein-bound drug? You'd have to say it would be higher, or it would be increased, right? Okay, other factors that are going to now go into metabolism, right? So we're going to typically find that the larger the gestation age, the longer the patient has had time to mature in mom, and the postnatal age, the more metabolism is going to be occurring here, right? Typically, you're going to find that other changes can be a factor here as well, including things like the size of the liver and proportion of the body, especially between neonates to adults. You're going to find issues here like disease states like congenital heart defects can affect things like metabolism just due to blood flow making it to the liver. A lot of features here we're going to look into in more detail. So remember, phase 1 reactions do what for us? They usually alter the drug. They're usually trying to uncover some sort of functional group, generally trying to make it more water soluble, right? Overall trying to make it more water soluble, so what can happen? You excrete it in the kidneys typically, right? So again, remember it's our oxidation pathways, the most important of which is cytochrome P450, right? It's the most important oxidation pathway you need to know. And again, what's the most important CYP enzyme? 3A4, right? You always want to know 3A4 if nothing else, right? Well, looking at the actual expression of cytochrome P450 in the neonatal period, you're actually going to find that it can be pretty variable depending on the enzyme you're talking about. Typically, though, the enzyme activity is around half for a full-term infant as what you would see with an adult, right? So basically, they're not going to be metabolizing as quickly. So what do you think that's going to do to our how we dose the medication? So you may not want to affect the dose necessarily, right? Because if you're trying to shoot for a certain concentration, but what else can I alter about how I give a medication? How often you give it, right? So you may find that when you have less metabolism, how is that going to change how often I give it? You give it less often, good, because I'm not having as much metabolism, so I may be giving drugs less frequently. So in these neonatal periods, you may find that drugs may have a similar dose to what an adult might get, but you may find instead of giving every 8 hours, maybe it's every 24 or every 36 or 48, depending on how the metabolism is actually occurring here. I'll give you some more examples of that in just a little bit. But looking at things like oxidation of phenytoin, some of the times you may even find that metabolism goes well above what the adult levels are. So as an example, phenytoin here, by 1 year of age, postnatal activity, you're going to find is 2 to 5 times higher than that of an adult. So what do you think that would do to our drug dosing? How we dose medication? So you may say, well, okay, well, the metabolism is going a lot faster. Maybe I would give it more or less frequently. Maybe more frequently, right? However, there is a limit to that, right, in terms of practical application. How often do you think is reasonable to give a medication in a day? 3 times, 4 times, 5 times a day, 6, 8, 12, 24 times a day? Right? Usually you don't want to really get more than Q8 or Q6 hour dosing, right? 3 or 4 times a day. So in some cases you may find that if you don't want to deal with having that really frequent administration that's impractical, sometimes you can get over by increasing the dose. So in these cases here you may find that phenytoin dosing will be much higher on a milligram per kilogram basis than you would find for adult patients, right? Based on the same dosing interval as you'll see there.
So earlier we talked about how the volume has increased and then that decreases the absorption into the GI tract.
Mm-hmm.
I heard about frequency being lower of the amount of dosage you give. So is it kind of like a crapshoot, figuring out what to do?
Well, so right, so you're just like, well, what the heck am I supposed to do with all this information, right? So we mentioned that the GI absorption can alter depending on how fast the gastrointestinal time is and things like the pH and whatnot. We're finding here that the metabolism here can be slowed or can actually be increased in some cases here. That is why, and again, the 15th thing that you should take away from this class, if nothing else, is that you got to look stuff up, right? So again, it's different for every single drug. But when you're looking up this information, this is why things are different, right? You think, why is this drug dosed this way versus this one this way? A lot of times it goes into the kinetics of the drug. So when you look that stuff up, you can see, oh, okay, that makes sense. I know that the sulfation pathway for children is much higher, and because of that, then I can give a drug this frequently, right? Or I give this dose of the medication. These are why these changes occur, and why you see neonatal dosing may be so different than pediatric dosing than adult dosing. Okay, so again, when in doubt, what do? Look it up, or call your local pharmacist, right? I may not be available at all times, right? However, look it up, right? Because again, you may be working in a place where a pharmacist is not available, right? You may be the only person there who's working. You got to figure it out, right? So again, this is why you need to look stuff up. Know your references. Know what's available to at your job. It'll be different everywhere you go. What resource we have at Nemours is different than what you have at Florida Hospital, different than what you have anywhere else. So again, figure this stuff out. Look it up. Make sure you know who your friends are to call when you need to figure some of these things out, right? So get to be friends with your pharmacists. Get to be friends with your lab staff. They can all help you out in different cases here, right? In general, be friendly. So that's why I mentioned like LexiComp is a really good one, and again, you have it available through Up to Date. So we use that at Nemours. That is kind of our standard go-to. There are a million different ones that are out there though. So if you use Hippocrates on your phone, that's a pretty decent one. It's not my preferred one, but it's a pretty decent one that you can get for free. If you go to, there's a reference called Neofax, which is just only neonatal information. There's a lot of different ones that are out there, right? And so that's part of what your schooling will do, and also rotations is you'll figure out what references are good for that. So when you do your pediatrics rotation, be like, hey, for this type of patient, what do you use as your reference, right? For this type of patient, what do you use for your reference, right? That's part of that learning process you're going to be figuring out there. And again, I know rotations seem like it's a million years away, but it'll come before you know it, right? I can't believe this past class is already about to be on rotations. It's insane, but and they were asking, they're like, well, how does this class compare to us? It's like, what do you want me to answer that? Anyway, there's no right answer. I said they're deficient every single way. I'm just kidding. No. The first year PA students, like every class is good, right? Until proven otherwise. You guys have not proven otherwise. That's good, right?
If you look things up and there's an error somehow from your source, does that protect you from malpractice?
Right. So you have to think about, what is the validity of the sources you're going with, right? So if you look up something on Google and it's a non-reputable website, then you may be held accountable for that, right? You're like, well, where'd you find this information at? Like, I found it on, some Facebook page. This is how to dose this vaccine or something. I don't know. Who knows? Whatever you might find. That's probably not a good reputable source. When you go to these references, though, oftentimes they're peer-reviewed, meaning that other people, it's not just one person just kind of spouting off whatever they think. It is other people coming in, other experts saying, hey, we agree with this. This is valid information. This is correct. And so that way you can say, I went to a standard drug reference. I dosed this based off of what was in LexiComp. I looked at the neonatal dosing, and this is what it said, and this is what I did. That helps to protect you a little bit, right? So you can say that, hey, I wasn't just a maverick, and I was just going off doing whatever I wanted. I was using a standard reference. So that's important to be able to do that. Because, again, if you make a mistake, someone's going to come back and like, well, why'd you do that? If you can say, well, this is what my reference was, this is what I was going off of, this was the hospital policy I was following, this is the X, Y, and Z, you can at least have something to back you up. You don't want to say, well, that's just what I did. I don't know. I have no idea why I did that. It's not a good answer, right? However, that is a very common answer, as you'll see.
So, going back to the cytochrome for
Yes.
And how it's approximately half in infants and adults. So you said you can decrease the frequency of the dose given, but can't you also decrease the error?
We're actually increasing the the dosing intervals increased. The frequency of how often you're giving it would decrease, right? So again, I want to make sure everyone keeps that in their mind straight.
But can't you also dose it differently as well?
Potentially, yeah. So.
Or just two options?
Yeah, those are two options, right? So again, in some cases, it may be not advised to change the dose itself, because maybe you're shooting for a certain level, right? Maybe you want to make sure you at least achieve a certain level, and if you give a smaller dose, you may not be able to do that. If you remember looking at that graph, that the different dosing strategies, I could give a bigger dose less frequently, or give a smaller dose more frequently, and those achieve vastly different levels. And sometimes you may need that really high level in order to get the effect you're looking for potentially. Yeah, so again, this is why it's different for every drug, and that's why you need to look it up. So that way you know, okay, for this particular drug, this is how I do it. And again, when you go out there to work, and I know a lot of you, when you're doing your interviewing, they said, well, why do you want to be a PA, right? What's the common answer you find on all your blogs? Lateral mobility. I can go from ER one day, and then geriatrics, and then neurology the next day, right? Is that true? Like, do people actually do that? not as commonly as you think, right? And most people, once they find their lane, they normally stick within that lane because that's what they like to do, you know? So when you do that, though, when you end up specializing and getting used to one thing, you tend to find that your stable of drugs that you use is fairly limited, right? If you work in ER, you're going to use a pretty standard stable of drugs versus if you work in neurology versus if you work in GI. You get very comfortable with those drugs, right? You get very comfortable how to dose it between this type of patient versus this type of patient. I'm kind of giving you the faucet, the water faucet full of all this information. You'll find that when you get into clinical practice, it'll narrow down quite significantly there, right? And that's when you see when something weird comes up. So if you're working in the ER and somebody comes in on a drug you've never seen before, like HIV medications, you're like, I'm an ER person, I don't do HIV drugs. You still need to be familiar with them and at least reach out to your resources when you encounter that stuff, right? So anyway, enough tangenting. Back to the topic at hand. Looking at this, so again, you're going to find the expression of these enzymes changes drastically depending on kind of where you're at. So sometimes it'll go above adult levels, sometimes it'll go below. It just depends on the actual enzyme itself. A lot of cases are going to typically find that half-lives will be longer when the expression of these enzymes is going to be lower, right? So, as I mentioned, things like for P450 within hours, CYP2E1 activity will increase pretty rapidly. Just the fact of being born will start to increase expression of that enzyme. CYP2C and 3A4, they're present within the first month or so, but they may not be during the first few days, right? So again, this is why I need to be really cognizant of this and recognizing, okay, well, my patient last week when I started this drug was 5 days old, but now that they're a week later, how do I need to change that drug dosing, right? So again, you typically will find in the NICU, usually every Monday, you kind of go through and you redose all the medications, because what else is changing on these kids? Their weight's changing pretty drastically as well, right? So again, you're updating the weight, you're going back and seeing, do I need to dose this differently because they're now maturing more? Those are things you're going to be looking at that, right? So also in phase 2 reactions, you're going to find that, again, what do we do with phase 2 reactions? We're adding something onto the molecule, methyl group, sulfate group, anything like that. Again, you're going to find there will be some changes here as well. What's interesting is that some of the pathways may be actually overexpressed, and actually, in some cases, you may actually find that they may be, again, well in excess of what the adult levels will be. A good example of this is acetaminophen. It's a very well-developed functional pathway, the sulfation pathway. And in fact, children are actually more protected against overdose with acetaminophen than adults are. Even example, for an adult patient, if they overdose on acetaminophen, I would become concerned and need to use the antidote at roughly 150 milligrams per kilogram. For a child, I can get up to 200 milligrams per kilogram before I am worried about them because I know that they have much better time metabolizing that drug away before I have to worry about things like hepatotoxicity. So again, in some cases, it could be even higher, and they can tolerate more drug than potentially an adult could. Okay. Other cases, you may see some issues here. A good example here would be something like morphine, right? If they can't glucuronide conjugate morphine very well, the drug sticks around for longer, and you may get more analgesic effect, right? You may also get more of those toxic effects as well that you can see. And actually, here's a really good example here of this glycine conjugation that is underexpressed at birth. One of the big things you're going to find if you work in the NICU is that you never ever want to use multi-dose IV products, right? So when you look at an IV vial, you look at those, next time you ever get a chance to look at one, and it'll say either single dose or it'll say multi-dose vial. Okay, multi-dose means that it contains preservatives that keeps it sterile, so that way I can go and take a dose out for one patient, and I can go back later and take another dose out for another patient, right? Again, it sounds grody, but we do that pretty frequently. So, for instance, think about insulin vials. Like insulin, that's good for 28 days after you crack it open, and patients have to go in and out of it pretty frequently there, right? You always use clean needles, using aseptic technique and all these things, but they have preservatives in there to keep them sterile. Well, there's one called benzyl alcohol that when given to a neonate, they can't get rid of that benzyl alcohol. They can't metabolize it well, and that builds up, causes metabolic acidosis, and they get this gasping syndrome that has occurred and actually causes death. So because of that, they don't use multi-use products in the neonate or the NICU because they worry about having that benzyl alcohol getting in there. So if you ever see like a preservative-free product, that's what that's referring to. There's no benzyl alcohol in it. Okay, that's safety. Yeah, so you can use a preservative-free product. You ever see PF after like an IV product? That means preservative-free, right? And so that's good for the NICU population because it doesn't have anything that they can't metabolize. So just to give you another example how this actually impacts us clinically. So then moving into excretion, you're going to find that, as I mentioned, most drugs get excreted renally. However, you're going to find that the number and function of the glomeruli are going to be altered depending on how mature the child is. Renal function tends to get pretty well compromised the more immature the child is in terms of their gestational age. But we'll look at some other factors here as well that can influence this. Looking at GFR, you're typically going to find that within the first week of life, the patient's serum creatinine tends to be much higher than what the actual resting level is. Now, why is that the case? Because we mentioned muscle mass for a neonate is typically higher or lower than the adult. Yeah, you don't see too many like bodybuilding infants, right? So muscle mass is low. So why is their serum creatinine higher? Whose creatinine are you measuring? Oh, you're actually measuring mom's, right? There's an equilibration between what's circulating with mom versus what's with the child. So in those cases there's an equilibration. It's a little bit higher. So you may measure a serum creatinine in a neonate and it looks like it's like 0.8, 1, 1.2, and you're like, well, that can't be that high. That kid doesn't have that much muscle. It's because you're measuring mom's creatinine. As they clear that on their own, it'll start to get lower and lower. And typically you're going to find that renal function does pick up during that first 1 to 2 weeks or so, especially as they start to diurese off a lot of that extra fluid they have from mom. However, what you're going to realize is that the more premature they are, the decreased GFR they're going to have, right? Because just the immaturity of the kidneys themselves, less renal blood flow in some cases there can affect how well we're excreting those drugs. And even if you're looking at a term infant versus preterm, right? Preterm being less than 1,500 grams, right? It's 1.5 kilograms. Just the other day we had a kid that was 500 and some odd grams. Very small little peanut. As one of those like 23, 24 weekers. And what you tend to find is that even though, looking at this, you see, okay, yeah, the renal function's pretty well decreased versus a term infant. What do you notice even 2 weeks later? It's still not even close to what the actual term infant is, right? So the renal function, even though they've been out for 2 weeks, it doesn't magically mature all of a sudden. It takes time, right? So it may be that whole first year while they're still developing and maturing before they actually catch up to where they should be, okay? So just another thing to note here as well is that's why this influences a lot of our drug dosing in terms of the interval that we're giving these drugs. So as an example here, looking at the GFR between, say, a neonate, say around 30 to 40 or so mLs per minute versus they get closer to adults, usually by 6 months or so, they should be pretty well close to the adult levels here. And again, with the neonate, we said that serum creatinine is not reliable because it's usually going to be higher than what we would think. How else can we monitor how well their kidney function is working? Yeah, looking at the urine output is the biggest thing, right? So making sure they at least have 1 ml per kilo per hour is generally pretty good. They'll get well above that for sure, but at least 1 ml per kilo per hour is generally pretty good in terms of urine output. We can either do that with direct catheterization or we can do it with weighing the diapers, etc. But it's usually easier in that period because, again, the kids are not really going to be fighting you too much, so compliance is usually pretty well ensured. So looking at the half-life of these drugs here, obviously drugs that are renally eliminated in the immature neonate, their half-life would be longer or shorter? Be a lot longer because they can't get rid of it, right? So gentamicin, again, is this example, is a water-soluble hydrophilic medication. It gets renally excreted, undergoes no hepatic metabolism. What you tend to find is that with a neonate, they're less than a week old, the half-life can range pretty drastically between 3 to 11.5 hours versus as you get older and more mature, so you get to around 1.5 to 3 hours.
Question.
Yes.
You mentioned before that for hydrophilic drugs, the volume distribution will be high in babies, right? But then their kidneys are not very well developed, so how is that not hurting them?
How do you balance it out, right? How do you actually balance that out? So this is the important thing. So consider gentamicin, we mentioned that to get the same serum concentrations to kill those bacteria, we had to do what to the dose to overcome the volume distribution? We had to give it a bigger dose, right? So to overcome the fact that they can't get rid of the drug, what do? I increase the interval, right? I give it less frequently. So when you're looking this stuff up, you'll see that, so for instance, if you go to Lexicon, look up gentamicin, they're up to date, you'll find that it'll say, okay, for a neonate, based on their gestational age, if they're less than 36 weeks or they're less than so many odd weeks, you dose it, say, instead of every 24 hours, you do it every 36 hours. Or if they're even more immature than that, then you do it every 48 hours. Which can be tough because sometimes, especially at us, when we're receiving a lot of these kids in, they may have gotten a dose at the original hospital, and if that documentation isn't good, then we may accidentally give a drug too soon, right? We may not have waited the appropriate 36 or 48 hours, right? And that's an important thing to consider is when you're actually redosing these medications due to poor documentation, right? Because it's going to be nice if everyone documented everything perfectly, but does that happen all the time? No. People are human, they make errors, right? So anyway, so that's how we overcome that. We have to give a bigger dose to overcome the volume distribution, but we give it less frequently to overcome the decreased clearance, okay? We're using both factors there to help with the kinetics. So again, that's why you look this stuff up, so you can see those changes there. Looking at things like tubular secretion and reabsorption, obviously that's going to be limited as well, especially the more immature the neonate is. But it should be getting up to adult levels around the 6 month to 1 year mark for those kids there. Also, you're going to have a harder time concentrating the urine quite as well, and you're going to find typically lower urinary pH values for them as well, which can affect reabsorption of certain drugs there in the renal tubules. Okay. So those are the main kinetic changes you're going to find in the infants there. Now, again, other factors that could play into why we see so much diversity in drug responses here. Also consider things like genetic polymorphisms, right? So again, based on the patient's genetics, it may affect how well they express certain enzymes. I mentioned before, remember how codeine gets converted over into morphine via that CYP2B6? 2D6. Remember that in some patients, they don't express that very well, versus some patients, they overexpress it. And again, that's led to deaths in some cases where too much of it got converted over to morphine, and they had respiratory depression. So again, that's a polymorphism that affected how the patient responded to that drug there. But again, consider all these things. Look at the factor, the environmental factors. What were the kids exposed to in utero that may have affected how they're responding now? Or was mom using cocaine the entire pregnancy? Was she using alcohol or heroin? And now the baby's withdrawing from those medications. That can affect how well they're going to be responding to treatment now, right? We have to give them other medications in order to compensate for some of that stuff. So a lot of factors that go into it. And again, this is a very heterogeneous population. When I say heterogeneous, what do I mean?
Very different.
Very different, right? So again, one neonate may be very different than another, right? So again, be very cognizant of these changes. Okay, and again, look at the pharmacogenetics of it. As I mentioned, some patients may have over-exaggerated effects, some children may have very little effects and may not do too well with it. What's interesting, though, is that CYP2D6 polymorphism, you typically see overexpression of it in black populations, which is actually interesting because, again, one other common genetic childhood disease that you're going to see more in black populations is also sickle cell disease, right? You guys familiar with sickle cell disease? Basically, it's where the red blood cells will they deform, they sickle, and they get sludged up into the vessels, and they have a lot of pain issues associated with that sickling, right? So how do we treat that? Well, we actually treat with opioids. And it makes sense that we use codeine for a lot of those patients, but it makes sense that it works well for them because they tend to overexpress that CYP2D6 and they convert a lot of it over to morphine. So little things like that actually make more sense when you dive a little bit deeper into it. Can be explained, again, in this case, by their ethnicity, right? Their polymorphisms, the pharmacogenetics of it. So looking at how we actually dose medications for pediatrics, you're going to find there's several different ways to do it. We'll look at the pros and cons of each here. But first, I think I'm going to give you a 10-minute break, and then we'll come back and look at this. All right, any questions from the first half? All right, let's talk about the different dosing strategies we have for pediatric patients. At the end of this section is where we get into the drug dosing, and that's where we're going to be more encountering the stuff for the last homework assignment. So don't worry too much about that. We'll talk about the math here in just a little bit. There'll also be math on your test. So again, I'll make sure you have calculators available, or if not, if that is not allowed, which has been in the past, so I don't know why it would change. If it does, it'll be math that is easy enough that you can do in your head with some scratch paper. Don't stress too much. It'll be fairly simple. Anywho, getting into dosing, we could do it age-based dosing, right? So as an example, maybe 2 to 5, you dose codeine this way. 6 to 12, you do it this way. What are some of the inherent disadvantages of using age-based dosing? Okay, so why is it important to have a weight?
2-year-olds might be totally different.
Right, so assuming every 2 to 5-year-old patient is the same weight may be inappropriate, right? So as an example, like my little girl, Lily, she's 3 years old. She's wearing like 5T, 6T clothing in some cases, right? So again, she's much bigger for her age than what you would expect to see for a typical 3-year-old versus like this 4-year-old she's hanging out with looks more like my 1.5-year-old. Suffice it to say, I have large children. It's just the case. They're very tall for their age. Anywho, but the fact is that they are very different weights as well. And so you tend to find that you may not have kids that are very consistent. Childhood obesity is a big thing. Some kids have conditions where they're very underweight, as the case may be. So this is difficult to use. We don't do it very frequently, okay? What is much more frequent and should be your kind of standard of practice for most of these kids is going to be body weight dosing, okay? So as an example here, you may find that for neonates and infants, you dose it, say, 20 to 30 milligrams PO divided Q12. For infants, you may find the dose will change, and then for adult dosing, you'll find usually pretty flat dosing in terms of that. Once you get up to adults, you tend to find less weight-based dosing as you do for pediatrics here. This is the most common scheme you're going to be using, but you do have to consider that some kids will be on the extremes of weights. You may tend to find, especially when you get up towards adult dosing, don't exceed that, right? Don't go beyond what the normal adult dosing would be. Now, how do we normally dose? Do you use pounds or kilograms? Always get used to using kilograms, right? How do you convert from pounds to kilograms? You divide by 2.2 from pounds to kilograms. How do I get from kilograms to pounds? Less frequent, you don't need to do that, but you'd multiply by 2.2, okay? Keep that conversion in mind because it's very common. If you ask a parent, how much does your kid weigh? They'll say 20 pounds, 30 pounds, right? You have to be able to convert that back over to kilograms because all of your drug dosing is going to be in kilograms, okay? So get used with the metric system there. Usually in neonates, you may find they'll be dosing, or they'll have grams of the weight will be expressed in, so keep in mind you don't want to screw that up, right? Because what's the difference between a gram to a milligram, or to a kilogram? It's a 1,000-fold difference, right? So you don't want to screw that up on accident there. So this is the most common way to do it. But keep in mind, though, like what's the most recent weight that you have on the patient, right? So if you have a kid who comes in coding, and you ask the parent, well, what's their weight? That might not be the most accurate, up-to-date one, right? It could have been the last time they went to the pediatrician, which was a couple months ago. Could be different, right? So those are things you want to consider there. But for instance, there's been medical errors where they'll have in ERs, they'll have scales that could change between pounds and kilograms, and someone will weigh it in pounds, enter it into the system as kilograms, and then now you have a dosing error, right? So oftentimes we'll do things like locking down our scales so they only weigh in kilograms, things like that are things you want to consider there. Disadvantages of body weight. Again, you can find over and under dosing potentially if you have kids at the extremes of either weight. I mean, I've had kids that have been 6, 7 years old that weigh like 30 pounds, right? Because again, they have conditions like cerebral palsy and things like that lead them to be very underweight for their age, and so you always want to take that into consideration there. Oftentimes, if I have a kids that are at the extreme high ends of weight, you have to call the nurse and be like, hey, just double check, like, are you sure you didn't accidentally enter the pounds in as kilograms? And they'll say, no, this is either a big kid or, actually I'm making a mistake. Usually it's the fact that they're probably a big kid, right? Because again, childhood obesity is a big problem here that we're dealing with. So things you want to consider there. If a weight looks funky, double check. You as the provider, you can visually look at the patient. Sometimes me as a pharmacist, I don't have that benefit if I'm up in central pharmacy, so I have to call you guys and get that kind of person on the ground sort of view of the patient. Anyway, yes, sir. What did I say? Yeah, so potentially if you are, say for instance, if you don't take into account things like the fact that they have altered kinetics based on being overweight or underweight, you may find that the dosing could be under or over, right? So for instance, you have a very lipophilic medication for an overweight child, you may find that you're not maybe dosing enough to get the correct blood levels for them, or vice versa.
I mean, like on the slide it says overweight twice, underweight.
On this line? Oh, okay. Yeah, for being... I see what you're saying. Yeah, so just say under or over. Yeah, either one. Sorry for the typo there. Again, Po buddies are perfect, as it turns out, including your professors. We are wrong on a very frequent basis. You guys just don't know enough to know it. Anywho, body surface area, right? So the nice thing about this is it actually factors in not only the patient's weight, but also their height into the calculation. I'm not going to bore you with all the calculations that are out there. There's a few different ones. Just get used to whatever they use in your particular field if you use it frequently. As an example, so there's a drug called corticotropin. You can dose 150 milligrams per meter squared. If you see that meter squared, that is their body surface area. It's height and weight being factored into it. The nice thing there is it actually will take away some of the potential over or under dosing if you have patients in the extremes of weight, because again, you are factoring in their height there. So that's kind of the more the benefit there. It's a little bit more precise. However, it's a little bit more labor intensive because you either have to have the calculator, you don't want to do it yourself in a lot of cases. So some things to note. This is the standard that we use for a lot of our chemotherapy dosing for cancer, right? So for instance, I'll have a drug dose of 1.5 milligrams per meter squared for, say, vincristine for leukemia, right, as an example. Again, it is a little bit more precise, but it's more labor intensive there. Okay. Also, how difficult is it to get an accurate height on a child? What about a baby? You think you just kind of stretch them out and you kind of weigh them, but oftentimes it's a two-person operation there. If you only have one nurse to do it, they may not get an accurate height there. If a kid has issues of spasticity, right, their legs are contracted, you may have issues getting accurate height there. Imagine getting a 3-year-old to stand still for more than millisecond? Not possible, right? So again, it can be sometimes difficult, more difficult than you think, to get the accurate height there. Also consider, did the kid have shoes on when they were getting the height? They were in their platform shoes? I don't know, right? So these are things you have to consider. Make sure their shoes are off, get an accurate height, make sure you're training that over time. Moving on to actual administration of drugs here, let's look at IV drug administration. So you have to consider a lot of features here, such as where's the actual site at? Do we have peripheral versus central access? Remember what the difference between that was? Peripheral means what? Usually in the extremity. Central means it's actually going to be a catheter that is being placed, basically the end of it, into the vena cava there to get better dilution. It's a little closer to the heart there. But also think about things like volume of drug, right? When I say volume of drug, what does that mean? How loud it is? How much volume? How much actual fluid do I need to give there? Because again, if you have a little 1 kilogram neonate and I'm giving them 20 mLs, that could be a significant amount of their actual body water, right? So you have to be very considerate how much volume you're giving, because you may find that you can fluid overload them in some cases, right? Be very careful with that. Also think about things like if you're getting a lot of labs, you're drawing it, you can actually induce anemias in some of these smaller kids because you're doing a lot of blood draws from them, right? So you can actually cause a significant decrease in their hemoglobin. Normally wouldn't see that with an adult patient. So think about that. Also think about things like, the actual technical problems of getting the IV access in the first place. It can be very difficult. The veins are very small. If they're not well perfused, you may need either the benefit of things like, ultrasound guided IV placement. You may need interventional radiology to come and place lines for you. Like you may need some extra help for some of these smaller kids, as you'll see. Normally, when you're giving the drug intravenously, you want to make sure that you don't just hang a bag and walk away. You need to make sure that the drugs are being administered at the proper rate and volume to make sure you don't accidentally kill somebody. So for instance, if I have a kid who's 2 kilograms, they're coming into the ER, and I just hang a liter of fluid on them, that may be way too much volume for them. And again, where's all that fluid going to end up? Eventually in their lungs, and they're not going to be able to oxygenate, and they're going to die, right? There's been cases of that where people just hang a liter of fluids, they walk away, and that whole liter infused into the patient, and they died. So you have to be really careful with this stuff, and that's why things like infusion pumps are very useful. So typically you'll find you have your drug either in a bag or a syringe or something, usually some kind of measuring device that will then be run through the line to a pump. It's a kind of old school pump, that's just an example, and then that will then be infused into the patient. Here's an example of a syringe pump. These are used for smaller volumes of drug that we're administering. So basically here the machine will be able to detect how big of a syringe that is, because it can detect the diameter there, and then it will then slowly push this in depending on how fast you want to infuse that drug. Okay. The benefits of using a system like this, which is pretty standard in pediatrics, is that it has a library built into it, meaning that if I say I want to give this drug way too quickly, the machine should hopefully stop me from doing so. Or if I'm trying to give too big of a dose or a non-standard concentration, that should stop me. That is the nice thing about these features here. Now, does that mean that the nurses are unable to bypass the safety features? They actually can in some cases, and that's a big no-no. That's a big compliance thing in our hospitals that you'll see, is to make sure the nurses don't go outside of this, because when they do that, what happens? They're more likely to make mistakes, right? We call it going off of guardrails, right? So again, you wouldn't want your roller coaster to go off a guardrail, right? Probably not. You want your nurses to stay on your guardrails too, and that helps to keep them safe, right? It helps to make sure they're not going to do things that could be incorrect potentially. Looking at oral administration, right? So looking at things like measuring devices. Now, normally, how do you dose oral medications for a pediatric patient, like the liquids? So you're talking about mLs, right? What is the more common thing we used to use? Teaspoon, tablespoon. Does anyone know how big of a volume a teaspoon is? 5 mLs for a teaspoon, right? How about for a tablespoon? 15 mLs, okay? Keep note of that, because when you look at a lot of the concentrations for these oral medications, they're expressed in per 5 mLs. That is because they're using the old tablespoon or the teaspoon sort of idea there, okay? And again, you used to dose medications by give 2 teaspoons every 6 hours. Give a tablespoon every 8 hours, right? What are some of the inherent problems with that? People may pour different. Well, what if I go to Walmart and get a spoon from there, a teaspoon from there, and then I go to IKEA and get a Swedish teaspoon? It's different volumes, right? You may actually find that the volumes are not going to be all accurate. So what do we do instead? We use accurate dosing syringes, right? So again, you can get these from the pharmacy. We'll have those in the hospital. You can get a dosing syringe that can actually accurately measure how many mLs of a drug you want to give. And when you're writing your prescription, that's how you should be expressing your liquid dosage forms. Say how many mLs that parent should give. You can say give 20 milligrams, and then the parents have to figure out how to convert milligrams based on the concentration into mLs. It's not going to happen, right? You guys are going to have trouble with it. Expecting a parent to do that who may only have a 6th grade reading level, educational level, it's going to be near impossible, right? So again, take all the guesswork out of it for them, be very explicit. Use 1.2 mLs, 7 mLs, whatever the case may be.
People even use the teaspoon tables, but it would not be easier to
We don't anymore, but that was the old way we used to do it. That's why we're trying to get rid of that stuff, right? So, but you'll see some remnants of it. You'll see some old legacy stuff where, again, if you see a drug concentration per 5 mLs, that's the remnant of that, is that old teaspoon sort of mantra there. Other things to consider, right? We mentioned a lot of tablets and capsules are not going to be appropriate for the younger kids. Sometimes you can find a 6-year-old that'll take a tablet. Sometimes you're going to find a 30-year-old who's not going to be able to take a tablet. It just happens, right? Some people have issues there of either texture or sensory issues there, but usually liquids are going to be the more common thing, okay? Now, what gets put into those liquid preparations, right? A lot of times, drugs may not be able to go into solution that well, and you have to use things like alcohol to put them into solution. Does that taste very good to a kid? Not really, right? It does not taste like a Mai Tai or something, right? It tastes pretty bad. And so kids may be less likely to want to take the medication. A lot of times, what do we put in them to make them taste better? A lot of sugar, right? That can be problematic for patients who are diabetics. Some patients, you ever heard of a ketogenic diet? Most people have heard of like keto diets. What's the cornerstone of a keto diet? High fats, but no carbs, right? So sometimes we'll do that for kids who have very difficult to treat seizure disorders. We'll actually put them on an extremely low carbohydrate diet. It actually induces a ketosis that puts them in a slightly acidotic state that prevents them from having a seizure, hopefully. Well, if I give them a bunch of liquid medications that have a bunch of sugar in it, and they don't take that into account, that can take them out of ketosis and put them at risk for developing more seizures. So these are things we have to consider, right? So if you ever see a kid who has a dextrose allergy, typically they're on a ketogenic diet. That is our way of trying to trigger people to know, hey, wait a second, I need to make sure I don't give this kid too much sugar, okay? Little things like that to consider. Drug-food interactions can be a big deal. A lot of kids like to drink milk. That can interact with medications and bind them up. And also have to consider things like inactive ingredients. Sometimes patients will have issues with certain dyes they'll have an allergic reaction to. There could be other non-active components that can also interact and be a problem, okay? So these are all little things we'll be thinking about. We think it's a problem with, if you make the medications. Because I remember when I took meds when I was a kid, they always tasted awful, right? What's the problem with like nowadays, like, you have like orange flavored ibuprofen, the grape flavored Tylenol. What's the issue with that? It tastes good, right? And so, again, it's not uncommon that we would get calls at the poison center and my kid drank the entire bottle of Tylenol. It's a problem, right? Because, again, most of the time we put them in containers that are not such a big dose that they could actually harm themselves. But also, it's important to make sure that you educate, hey, this is not candy, don't treat it as such. Sometimes parents will be like, oh, take the candy, like, drink the juice, and they think, okay, this is juice, this is food, this is candy, this is good. Not great to set that up in their mind, right? Oftentimes they'll try to mimic parents and they'll get into stuff like that. It's a big issue. I can't tell you how many times parents call up and say, my kid ate like 60 of these gummy vitamins. They're gummies. They look like candy. They're designed to look like candy, and as such, kids treat them like candy. Fortunately, we take all the dangerous stuff like iron out of it so they can't get into too much trouble, but it's a very frequent thing to see a lot of pediatric poisonings due to this stuff. But anyway, other things to consider, always make sure you get an accurate weight, at least as most up-to-date if you can. Weigh them at the time that you're dosing if possible. And then always check with your available references. Like I mentioned, there's a pediatric section of LexiComp. Go with that. It's always going to have good information there. You may need Neofax or something like that, similar for neonates potentially. But go with your resources that you're comfortable with. And as well, when you're counseling patients, make sure if they're old enough, speak to the patients. Like make sure they're going to be an active participant in their own health, and make sure you can educate to their points. Right. Also consider though that some of the adults may not have much of a medical background, and you need to make sure things are simple for them as well. Right. Make sure they understand how many mLs they're supposed to be administering, how often they're doing it, etc. Okay. So getting into the actual drug dosing calculation. So this is probably going to spend some time here. Make sure that you understand how to do this. If you can understand how to do these simple calculations here, this will carry you out for the rest of your drug dosing for your careers for the most part. Okay? It's pretty simple, but you need to do it a couple of times. You need to practice with it in order to feel comfortable doing it so that way you can be confident for the test and for your actual dosing when you're doing this in the future. If you can do this confidently, when you get on rotations, you're always already going to be heads and shoulders above other students out there, right? Because a lot of people have a lot of trepidation with this. They worry about this. They worry about getting something wrong and hurting a kid. But you can feel confident if you know your math, you know the right information, you can dose with no problems, okay? Pediatrics is easy once you're used to it. But a lot of people feel very hesitant to do so when they don't deal with this population. If you ever want to see the most anxiety-filled room you've ever seen, go to an adult ER and bring in a pediatric code. it'll be everyone is blood pressure is about 200 over 100. Everyone is so freaked out, but it's because they're not comfortable doing things in that population. If you're used to it, it's easy, right? But you got to know what you're doing. So let's get into this. Let's say, and again, knowing the drugs isn't so important, right? We'll go into the drugs next semester, but again, the math is what's important here. So looking at this, we have a 15-kilo kid that is going to get amoxicillin for an acute otitis media. It's a very common script you might write if you're in the pediatric realm. The dosing is going to be 90 milligrams per kilogram divided BID. So right off the bat, what does that mean? How much are they going to get actually per dose? 45 milligrams per kilogram, right? So keep these relationships in mind because you're going to find that these instructions may be written a lot of different ways, and I'll show you some examples of that in the upcoming examples here. The concentration of amoxicillin is 400 milligrams per 5 mLs. And again, why is it per 5 mLs? That's what a teaspoon was, right? And that's how we used to dose things and how many ever teaspoons you're supposed to administer. So the question is, how much should this child receive per dose in volume, not necessarily in milligrams, because the parent doesn't care the milligrams, they care about the volume. Nurses as well, they don't actually care how many milligrams they're giving of a drug. They care about how much volume they need to administer to get that right dose. Okay, so volume is the important thing here. How would we do this? Let's look at the step-by-step approach here. So first off, how much should a kid get per dose? We need to figure out what the actual dose per day is the patient should get. Okay, so what's the first calculation? 90 by 15. So we're going to take, to figure out the dose per day, we should get 15 kilograms per 90 milligrams per kilogram per day. Okay, what cancels out here?
Kilograms.
The kilograms cancels out, right? This is basic algebra stuff, right? But keep your units straight. If you keep your units with you when you're doing this stuff, you can't get into too much trouble. If you lose your units, this is where trouble happens, okay? So keep your units straight. So the kilograms will cancel out here, and thus I get the patient should receive 1350 milligrams per day. Okay? Am I done now? No, I must continue on, right? So I got to figure out how much volume they should be getting per dose. So now I'm going to say, okay, well, I know it's going to be given twice a day. I know it said divided BID, which is twice daily. So I'm going to take that 1350 divided by 2, and so they should be getting 675 milligrams per dose. Am I done now? No, I must continue on, right? So I got to figure out how many mLs they need to get. So 675 milligrams per dose. So what do I do with the 675? Well, basically I'm going to take, and again, one handy thing you can always do, if you see a drug concentration being expressed as per 5 mLs, convert it down into per 1 ml, right? Figure out the milligram per ml concentration, and that'll ease your calculations. Don't get scared by the per 5. You can just divide that out and get rid of it, okay? So I know that it's 400 per 5 mLs, so I'm going to equal, or just divide that out, and it's going to be 80 milligrams per ml. So that means for every ml of amoxicillin suspension I have, it's 80 milligrams, okay? So then I'm just going to take that. I will then take my 675 milligrams per dose and then divide that by 80 milligrams per ml. Doing that calculation should equal out to 8.4 mLs per dose, and that is how much you should be giving your patients. When you write that out on a prescription, you'd say take 8.4 mLs by mouth twice daily. Okay? Everyone with me so far? Again, it seems cumbersome, but again, when you practice it, it'll make more sense as you go along. I'll show you some more examples of this in a few seconds here. Again, now, could you round this at all? The nice thing is we have dosing syringes. You can get pretty accurate with this stuff. If you give 8.5, it's probably fine. If you give 8 mLs, that's probably fine. Usually if you're rounding within 10%, you can't really get in too much trouble, for the most part, okay? Especially like, antibiotics and things like that. Okay, well, let's try another example here. Let's look at a drug called ranitidine, which is an over-the-counter medication used for GERD symptoms, right? It's an acid blocker. It blocks H2 receptors. But it's going to be dosed at 4 milligrams per kilogram per day divided BID. It's 18 kilogram patient we're dealing with, and the syrup comes as a 15 milligram per ml concentration. So how much should this patient receive? So let's go through it right now. I intentionally did not put all the instructions here, so that way we can work through it together, okay? So, and again, I'm going to pull up my calculator to make sure I'm doing it right, because I don't remember what the actual answer is anyway. Because I do the stuff the same as you have to do it, right? So anyway, so let's look at this. So we have 18 kilogram patients. What's our first step here? Yes, okay. And again, I'm left-handed, and I'm also using a mouse to draw this stuff out. So again, please bear with my my handwriting here, right? So 18 times, and I'm not going to put my units here because that'll take me too long. So 18 times. That was 2? Why 2? Because we're dividing it BID, but let's go ahead and stick with just per day so far, right? So let's go get the milligrams per day we're going to do. So we're going to do 18 times 4, right? Equals 72. So that patient should be getting 72 what? milligrams per day, right? So again, we're still at per day. All right. Again, I can write a little more legibly than this, but this is about as bad as it gets. Okay. So what's my next step? Divide that by 2, right? Because again, I'm giving this drug every 12 hours or twice a day, so I divide this by 2. So 72 divided by 2 is, so divided by 2 is equals 36. Okay, so 36 what? Milligrams per dose, right? So keep your unit straight. It's 36 milligrams per dose, okay? Now what do I do?
You know that 50 milligrams is in 1 milliliter, so how many milliliters?
So do I need to, so getting to that concentration of the drug, do I need to divide that by 5? Why not? It's already in per ml, right? So it's already 15 milligrams per ml. So I can just take that 36 milligrams per dose, divide that by 15, and I will get my mLs per dose. 36 divided by 15 is 2.4. So 2.4 mLs per dose. Okay?
That's 1/6. That's 1 by 6.
It'd be given twice a day, right? Because again, we divided it BID. So you, in your instructions, you would say take 2.4 mLs
Twice a day.
by mouth twice daily. Okay? Again, it's the same calculations over and over again. You just got to make sure you're following the right process and keep your units straight here. Okay? Let's look at another example. Let's get it a little bit more complicated. So this is a drug called Bactrim or Septra. Most people probably heard like Bactrim DS before. It's commonly used for things like UTIs and skin infections and whatnot. But this is actually a combination drug. It's a mixture of 2 called trimethoprim and sulfamethoxazole. Whenever you're dealing with a combination drug like this, you always want to figure out which component you're dosing by. Because it always comes as a fixed concentration between the two, a fixed ratio, but usually the drug references will say, hey, we're dosing it based off of this component. Okay, so let's look at this. So we have a 12 kilo patient who's getting Bactrim for a cellulitis, cellulitic infection. They're getting 4 milligrams of TMP per kilogram per dose BID. Okay, so this TMP stands for trimethoprim, which means that you're dosing off of that concentration there. That you're basing off of the trimethoprim component. Okay, so let's keep that in the back of our minds. The suspension comes as a sulfamethoxazole 200 milligrams and trimethoprim 40 milligrams per 5 ml solution or suspension. You know the difference between a solution and a suspension? Solution is a homogeneous mixture. It's well distributed, right? Suspension has larger particles. They tend to fall out due to gravity. So what do you got to tell patients to do before you give it? Shake it up, right? A lot of times patients may forget to shake it up. That means all the drug's at the bottom, so they're not getting any drug for the first part of it, and then they get all the drug at the end of it. It can be a problem, right? You get low efficacy, and then you get all the efficacy all at once in terms of toxicity. Anywho, so how are we going to tackle this problem? What are we going to do? Yeah, so let's figure out what our first of all what our dose is going to be here. So looking at this, I can find my mouse. Okay, so it's going to be 12 kilograms times what? Times 4, right? Equals what? 12 times 4 is 48. So 48 milligrams per what? Per dose. Now what do I do? Do I divide by 2? Exactly, right? This is why the units are super, super important. Before, we saw they were in milligrams per day divided BID. This is not the case. It says 4 milligrams of trimethoprim per kilogram per dose. I'm giving it twice a day, but it doesn't mean I have to divide that dose out. Okay? This is where it gets tricky because drug references will have both of those in there. And you need to make sure you're reading your units correctly. So in this case, I do not need to divide by 2 because it's already in a per dose configuration, right? Good. So now what do I do? Yeah, so now let's figure out the concentration per ml of our drug here. Now, what do I need to divide by 5? The 40, right? Because I'm dosing it based off the trimethoprim content. Actually, the sulfamethoxazole I don't really care about because, again, it's in a fixed ratio. I don't have to think about it. So, but I take that 40 milligrams per 5, and what do I get? 8, right? So this is actually an 8 milligram per ml concentration. So then I can take my 48 milligrams and do what with it? Divide by 8. What do I get?
6.
I'm getting 6. Just double check. 8 divided by 8 is 6 mLs, right? 6 mLs per what? Per dose, right? So I'd be giving sulfamethoxazole trimethoprim suspension, 6 mLs by mouth, twice a day, right? Yes, sir.
So you don't have to have it because it says dose.
Yes, because it already says per dose. If it said per day, it said TID, then what would I do? Divided by 3, right? If it said, you know, how many ever milligrams per kilogram per day divided QID, I would do what? By 4, right?
So the first ingredient is sulfamethoxazole.
Uh-huh.
It's happens to that.
So it's a fixed ratio, so you don't have to think about it. Because again, as long as I'm dosing off the trimethoprim, then I'll get all the correct amount of sulfamethoxazole automatically. Because again, it's there, right? You know, it's in that fixed ratio. I don't have to think about that. However, what could be a potential error here? Well, what if I dose it off the sulfamethoxazole concentration? My dose be too big or too little? Be too big or too little? Because this is 200 milligrams per 5 instead of just 40, it would look like it's much more concentrated, so I'd actually give too small of a dose there. So I'd undertreat my patient, and that cellulitis wouldn't get treated, and then it would develop and potentially turn into, who knows, sepsis or something, right? This is why you got to be really careful and make sure when you're looking at these things, double check yourself, double read, and make sure that it's all correct there, right? Now, again, it's easy when you think. I've been talking to some PAs recently, and they're like, "Oh yeah, it's super easy." Actually, we were doing a sim. Some of my students had graduated in the past couple of years. They come back and they're talking about how they're working and what they're doing. They talk about their EMR, right, their electronic medical record system, and they're like, "Oh yeah, I just click the buttons and boop boop boop, and then it just automatically figures it all out for me." It's all well and good, but sometimes you need to be able to do this by hand, right? You need to be able to figure this stuff out and double check yourself to make sure what the computer does is exactly what you want it to do, okay? Or again, I had one time I had a doc, they were recently graduated from a Peds Emergency Medicine Fellowship, and our system went down, our computers went down, and she's like, "Oh, I need to write a prescription." So I said, "Well, here's your prescription pad." And they said, no, I've never written a prescription before. They just never had to, right? Because again, they grew up in the age of computers and stuff. However, downtimes happen, so you guys have to know how to do this stuff, which is why I have you do this on the prescription assignments. You'll be very well versed at doing this. And a lot of offices you go to will still use paper prescriptions, right? So again, it's not that uncommon. Yes, sir.
Do you always have, for the suspension, is there ever a time when you do both, or is it always one?
Do both. You mean dose off the?
Dose off.
Well, because it's at fixed ratio, it's always going to be the same, right? So again, you would always make sure that you're dosing off of one component or the other. But again, your reference will tell you what you're dosing off
So
of.
you can either do 200 milligrams per 5 milliliters. You can base it on that, or you can.
No, because all your drug references, and again, you typically find, as you work with these drugs, you'll kind of figure out which ones they're basing off of. They standardize it, right? So again, you're always dosing off the trimethoprim content. That's just standard. We've been using this drug for decades and decades. That's just what we do.
You just look it up. If you're not sure.
Yes, always look it up.
Okay.
That's the key for the entire class. If you're not sure, look it up.
Is there a significance why sometimes the usual dose is per kilogram per dose versus per kilogram per day? Or because
I wish I knew.
it's not because, one drug might be eliminated faster.
Nope, no rhyme or reason to it. Nope, it is just the way they do it. Because again, this could have said what? They could have said 8 milligrams of trimethoprim per kilogram per day divided BID. That would have been the same exact thing, right? However, this is just how the nomenclature went, right? So again, always look this stuff up. Be very careful in your units when you're looking at it. Okay. Let's say we have a 20 kilogram child who's getting 2 teaspoons of acetaminophen 4 times a day for fever, right? Acetaminophen, what's the brand name for that? Tylenol, good. Usual dose is 15 milligrams per kilogram, and it comes as a suspension of 160 milligrams per 5 mLs. And mom's coming to you, they come to the ER, they say, "Am I giving enough to my kid?" Because oftentimes you'll have parents will come in, they say, "I gave them this much ibuprofen, I gave them this much Tylenol." And it could be an incorrect dose, it could be too much, too little, right? So they come in, they still have a fever, and they were given too little, that I can supplement and give them the extra they need, right? Or if they are given too much, I can correct them and say, "Hey, don't give this much, give this much instead." So let's figure out, is this an appropriate dose for this patient, right? So first off, we have to figure out, well, how much are they actually receiving per dose, okay? So how much are they getting? So we said 2 teaspoons, 10 mLs, right? So I know the patient's actually getting 10 mLs per dose, right? Okay. Now the question is, well, how much is that in milligrams that they're receiving? So first I have to figure out my concentration of the Tylenol here. It's 160 per 5. Anyone know what that turns into? Can I divide that out? 32 milligrams per ml. It's a standard concentration for a Tylenol. Now, back in the day, they used to have infant formulations of Tylenol and ibuprofen. There's a different concentration. What do you think was the problem with that? they get mixed up and get one to be given to the other size kid, and they get all kinds of funky doses. They've standardized and got rid of a lot of those different ones. Now we have very standard sets. So this 32 milligrams per ml is always the Tylenol suspension you're going to run into. Anywho, so okay, so you're getting 10 mLs, and they're getting 32 milligrams per ml suspension. So how much of a dose are they getting?
So they're getting 32 milligrams in 1 milliliter.
Yep.
So how many milliliters?
Times 10 milliliters that they're receiving.
32.
Yeah, so I'm going to take that 32 milligrams per ml, right, per ml, times the 10 mLs are getting. What cancels out? The mLs will cancel out, and that equals 320 milligrams, right? Seems simpler than it was, right? So again, 320 milligrams. So the question is this an appropriate dose for that patient? How would you figure that out? You look it up, right? Well, I already told you, right? I said it's 15 milligrams per dose, or per kilo per dose. So now I need to figure out, well, how many milligrams per kilogram was this patient receiving? So I can take this 320 and then I divide it by what? Divided by the patient's weight, which is 20 kilograms, right? Divide by 20, and what do you get? 16. So 320 divided by 20 equals 16. What? This is milligrams per kilogram. Is this appropriate? If the dose is 15 milligrams per kilogram, is that within 10%? Pretty close. Yeah, I'd say yes, you're giving the right amount. Okay. Yes, ma'am. You could have figured out what his dose should be and then compared to what he was actually getting. You could do that too. And actually, you can do that to double check yourself to make sure you're getting the same answer, right? But again, this is probably the more common. This is how I go about double checking your guys' math, right? So again, if you write for something, I can go back, and this is how I go backtrack it to make sure that it's an appropriate dose for that patient, okay? So again, you'll find both ways will be done depending on what the situation is, okay? Because again, part of my job is always double checking to make sure that our Swiss cheeses aren't meeting up, right? The holes don't line up, and make sure that your dosing is correct there and the volume is right. Okay, so that's pretty standard, right? So again, the prescription assignment will be 2 drugs you're actually dosing like that. So make sure you're going to go through and can do the math there. You can practice with it. One other thing I want to focus on here is fluid dosing for patients. This is a good standard thing just to know, especially for rotations, especially it applies to almost any patient you're going to run into, right? But specifically for peds, this is important. So when you're giving fluids, there are 2 ways you can do it. You can either give a fluid bolus or you can give what we call maintenance rates. What do you think a fluid bolus is intended to do? Well, just like yeah, you're right. So just like we would give a loading dose to get a patient up to a certain concentration of a drug, we're trying to get them up to a certain volume status, right? So if a patient's coming to have a ton of diarrhea and they're vomiting and they're dehydrated, this fluid bolus is meant to get that intravascular space filled back up to give them more fluid to rehydrate them, right? So oftentimes if a patient comes in, they're hypotensive because they have low volume, we will give them a bolus of fluid to perk them back up, right? And again, a lot of your patients, all they really need is a liter of saline. They're going to feel a lot better afterwards. But we're going to find that may not be the right dose for everyone. Normally think, oh, give them a liter of saline. You're good to go. 2 liters of saline. But for pediatrics, you can't do that because a lot of them are much smaller, and that is an inappropriate amount. So a standard amount to give for a fluid bolus for a child, actually you can apply this up to adults in a lot of cases, is 20 mLs per kilogram. Okay, that's a standard. Now, if you had someone who could not receive a ton of fluids due to like renal compromise or due to they're already fluid overloaded, then sometimes you give 10 per kilo. But 20 mLs per kilo is very standard. You give that to most of your patients and are not going to have any issues with that. Okay. And again, we'll get more into the different types of fluids later on. We'll talk more about that, but I kind of wanted the math to be involved here now. The next thing you got to figure out is the maintenance fluids. And what do the maintenance fluids do for us? They keep us at the same level, right? Because again, we're always losing fluids, right? Either through urine, through sweat, through breathing. Like we lose fluids in a lot of ways. This is meant to keep us at a certain volume status, right? And so this is what we call maintenance IV fluids, okay? And what we have here is called the 4-2-1 rule. This is very standard for pediatrics. You should be doing this for most of your pediatric maintenance fluids you're going to find. If you're admitting someone to the floor, chances are you'll probably put them on maintenance fluids. This is how you figure out the rate, okay? The 4-2-1 rule goes as follows. And again, if you practice this, it'll make more sense because it seems a little nonsensical when I first mentioned it. For the first 10 kilograms of a patient's weight, it'll be 4 mLs per kilo per hour, okay? Now notice, why isn't there a per hour on this fluid bolus? It's a one-time thing. I'm just giving it to them, probably over the course of, say, 10, 30 minutes, and then it's done. versus the maintenance fluid should be continuous, and so it's going to be given per hour, right? So that's the difference there. That's why it's per hour. The second 10 kilograms of a patient's weight is going to be 2 mLs per kilo per hour. And then for every subsequent kilogram, it is 1 ml per kilo per hour. And you're like, what the heck does that mean? Well, let's work through it, right? So let's look at, say for instance, we have an 8 kilogram infant. So based off of that, what would be their fluid bolus dose? Is it 80 or is it, what's the dose? 20 mLs per kilo. So I multiply by the patient's weight. 20 times 8 is 160. So for this patient here, the infant, they would be getting 160 mLs as their fluid bolus, right? And then their maintenance would be what? Well, they're not even 10 kilos, so I only have to worry about this first rule here. I only have to worry about this first part here. So that's 4 mLs per kilo per hour. So that would be what? So 8 times 4 is 32. So they would be getting 160 mLs as a fluid bolus, and they'd be getting 32 mLs per hour. Right? The kilograms cancel out there. Right? So that one's easy because I only had to worry about the first. I only had to worry about the 4 out of the 4-2-1 rule. Okay. Let's say we're dealing with a 1,200 gram neonate. What does that convert into in kilograms? Yeah, so you're gonna make sure you can do those conversions there between grams to milligrams to kilograms, right? It's all factors of 1,000, but this is basically a 1.2 kilo patient, right? What would be their bolus dose? How'd you figure it out? 1.2 times 20, right? This is really that simple, you know? So 1.2 times 20 is how much? 24 mLs, right? Is that a lot of volume?
No.
That's not. It's like nothing. How much is an ounce of fluids? 30 mLs. One fluid ounce is 30 mLs. How much is a shot of tequila? 1.5 ounces, 45 mLs. This kid's not even getting a shot worth of fluid for his fluid bolus, right? It's a very small kid. So I just wanted you to think about the volumes you're actually giving there, right? Again, very small volumes we're dealing with. What would their maintenance rate be? Be 1.2 times 4, absolutely, right? So again, it'd be 1.2 times 4 equals 4.8 mLs per minute, day, hour, right? Per hour. Keep your units straight. Main thing is like, why is he harping on these units so much? This is how you screw stuff up, and this is how you kill people, potentially, right? Or undertreat them, or overtreat them, is by screwing up your units, okay? One time I had a doc and an anesthesiologist, right? So like they know their pain meds pretty well. Our computer system for the drug fentanyl, right? Fentanyl is a very strong opioid. It's dosed in micrograms. Our system was designed so that it said you just would type in, there'd basically be a box. You're gonna say micrograms per kilogram. You guys are all gonna think I did not go to kindergarten or something, per dose. Okay. Now normally that dose would be say 0.5 to 1, right? You just type it in and then the math would figure itself out through the computer system and you'd spit out your dose, right? The patient was 10 kilos. And so the doc was like, okay, well I only want to write for 5 micrograms, so what did he do? Well, he wrote 5 into this box here. What do you think it turned into? 5 mics per kilo per dose. This is a way higher dose than what he anticipated. So when it came out to be like 2 milligrams of fentanyl he wanted to give, 2 milligrams, as opposed to the 5 micrograms he intended, that's a huge overdose. That would have killed the patient, right? Fortunately, we flag that kind of stuff when we catch that sort of stuff. But this is how you screw things up. Like, you got to watch your units, okay? So be very careful. Even the computer systems can't fix some of these issues here, right? Okay, getting back into it. 45 kilogram adolescent, right? So now we get to involve more of the 4-2-1 rule in this. Starting off, though, what would be their fluid bolus? So 45 kilograms times 20 mLs per kilogram. What do you get? 45 times 20. 900 mLs, right? How much volume is a liter? 1,000 mLs, right? So they're almost getting a liter. Would it be wrong to give that patient a liter? Probably not. Right? It'd probably be fine, right? But strictly speaking, 900 mLs would be the correct fluid bolus for this patient. Now, what would be their maintenance rate? So to get that, you would see, okay, well, for the first 10 kilograms of this patient's 45 kilogram weight, it's how much? 4 ml per kilo per hour. So it means for their fluid rate, and again, I'm just going to kind of divide this out, or just separate that. So for the first 10 kilos, I'm going to get 4 mLs per kilo per hour times 10 kilograms, right? And what do you get? 4 times 10, 40 mLs an hour, right? Again, I know it seems like, wait a second, it can't be that simple, right? It's that simple, right? It's okay. So for the first 10 kilograms that patient's weight, he's getting 40 mLs per hour, right? So 40 mLs per hour. So then for that second 10 kilograms of his weight, he gets how much? 2 mLs per kilo per hour. So it'd be 2 times 10, you get 20. So now we got 40 plus 20. And then now we do 1 ml per kilo per hour for every ml after that. So how much do we have left over? If we do 20 kilograms that patient's weight, what do we got left over? 25 kilograms. So I do 25 times 1. So I do plus 25. And that patient's maintenance rate would be what? 40 plus 20 plus 25. 85 mLs per hour. 85 mLs per hour, yes ma'am. Absolutely. So the bolus makes sense, right? So it's 20 times their weight. So that's pretty straightforward. So for the next part here, and again, I'll do another example with the 100 kilo teenager, but the 45 adolescent, basically for the first 10 kilograms of their weight, it's 4 mLs per kilo per hour. So 4 times 10 means 40 mLs per hour you're getting there, right? For the second 10 kilograms of their weight, it's 2 mLs per kilo per hour. So because the patient weighs more than 20 kilograms, I say, okay, well, 2 times 10 is another 20 mLs per hour. So I got 40 mLs per hour now for the first 10 kilograms. I have 20 mLs per hour for the second 10 kilograms. And now from every kilogram past that, it's 1 ml per kilo per hour. So because I've already used up 20 kilograms of the patient's weight, I have 25 left over. I do 25 kilograms times 1 ml per kilo per hour, and I get left over 25 mLs per hour. So I add those up, so 40 plus 20 plus 25 equals a total of 85 mLs per hour. Okay? And again, you can practice. You can come up with your own patient weights and just work through it, right? You'll get to the point where you can do this in your head very quickly, right? So if I see a 60 kilo patient, I can very quickly go through and actually come up with a maintenance rate, just like you'll be able to do. And that's what we do to double check ourselves. You'll write the maintenance rate, I get the order, and then I'll verify it, make sure it looks good, and then we'll verify and say, okay, you're good to go, right? This stuff will come to you naturally. It just takes time and practice, okay?
After the first 20, can you just take, like, whatever their total weight is, minus 20, and then times that by 1 to do the rest of it?
Essentially, right. So if I see a kid weighs like 30 kilos, I just say, okay, well, I do 60 plus 10. Yeah. So you'll get that quick. But again, I want to make sure I'm going through it slowly for people the first couple of times, right? So let's look at a kid who weighs 100 kilograms, right? So let's say we got one of those football players from World of Sports, got injured, and coming over to us. What would be their fluid bolus? 2,000 mLs, right? So again, you can give up to 2 liters for patients if they need that fluid bolus, right? Sometimes you may be more cautious and say, I'll just give 1 liter, but this kid could get 2 liters, no problem, right? So again, 20 times 100 would be 2,000, or just 2 liters, right? Okay, that makes sense. Now let's figure out what their maintenance rate would be. The maintenance rate is going to be 4 mLs per kilo per hour times the first 10 kilos. So it's how much? 4 times 10 is just going to be 40 mLs per hour. So it doesn't matter how big the patient is. That first 10 is always going to be 40 mLs per hour, right? Now, that's going to be plus the second 10 kilograms, which is 2 mLs per kilo per hour, which is what? 20, right? So again, so 2 times 10 is going to be 20 mLs per hour. Now, how much do we have left over?
Well, you still got 80.
Plus, okay, so I've already used 20 kilograms out of that 100 kilogram patient. I got 80 left over, so that's what now? 80 kilograms times 1 ml per kilo per hour is 80 times 1 is 80. mLs per hour. So what's my total? Equals, so it's 40 plus 20 plus 80, so 140 mLs an hour. Now there are other ways to calculate this stuff. Like there are other more like if you ever see like a Holiday Seeger method that does it like in mLs per day. This is you get essentially the same answer, right? Maybe within a few mLs of one another. But this is the quickest, dirtiest way to come up with the maintenance rate. You could use this for adult patients. It is totally fine. You'll get almost the same answers you would for anyone else, right? But this is primarily seen with pediatrics. You had a question first?
So it's pretty constant. I mean, anything that really changes in mid-class hour. So if you can just keep track of like minus 20.
Yeah, but be careful if you have a patient who say was, for instance, like say 15 kilos, right? Because then they don't follow up, they don't get that full second 10 kilos there.
Okay.
So for someone who say was 15 kilos, it'd be 40 for that first 10, and then you do 2 times 5, and so you just take that 10 added on, so you know, that's 50 mLs per hour. Okay. So, but yeah, otherwise it's very constant. Yes, sir.
This is for like every
IV fluid, yeah. So if you're giving a bolus fluid order, usually 20 mLs per kilo for 90% of the patients you're going to deal with. If you're doing maintenance fluids, this is exactly the way you can do it. Yes, ma'am.
So it's pretty much going to be, as long as they're over the 20 kilos, you're going to have the 60 plus 4 times whatever.
And like the way my mind works when I'm reading those orders, I'll look at the patient's weight and I'll do, okay, if they're 30 kilo, do 20, 40. I'm sorry, I'll do 40, 20, and then whatever the remainder is. But if it works better for you, say, okay, I'll do 60 plus whatever, then that's fine. But just practice it, and it'll make more sense as you go through it. Yes, ma'am.
So are we talking about like just any fluid? It doesn't matter if it's isotonic or if it's
Exactly. Yeah. So there may be some cases where maybe you want to go above that. So this is just a flat maintenance rate, right? So if you had someone who's maybe having some ongoing additional losses, maybe they had some extra diuresis going on, or maybe they're still continuing to have a lot of diarrhea, you could go above this, right? So if you ever see someone say, "Oh, I'm going to do 1.5 times maintenance," you just do 1.5 times whatever maintenance rate you come up with, right? Yes, ma'am. Yeah. So say we had a 15 kilo patient, right? So 15 kilos. So for them, their maintenance rate would be what? So 40 mLs per hour for the first 10 kilos, right? Plus 2 times 5, because it's 2 mLs per kilo per hour times that 5, so plus 10 equals a total of 50. Right? Yeah, because in that case, you used up 10 kilograms already, you got 5 left over, because it's not beyond that. The 2 rule, I do 2 times 5, and I got 10 from that. So if it was 13, it would be 40 plus 2 times 3, which is 6, right? So that patient would be 46 mLs. If it was an 18 kilogram kid, 40 plus 16, 56, right? So again, practice it, come up with the problems for each other, kind of work through them, and it'll make much more sense there, right? Okay. One last thing I want to make mention of here is if you ever see a drug expressed in percentage, and I'm running up on time here, but if you ever see a drug expressed in percentage, there's a very easy way to convert this over into a more practical number, right? So if you ever see like bupivacaine 0.25%, right, 0.25%, if you ever see a drug 20% solution, there's an easy way to convert that over into milligrams per ml, and it's very easy. So for instance here, let's say I'm using the drug lidocaine 1%. I want to numb up a laceration so I can suture it, right? Not me personally, but you would do this, right? I can convert this and determine how much I can actually give this patient, because if I give too much lidocaine, you can see toxicity. The way to do this, anytime you have a percentage of a drug, so say for instance I have a 1% solution, right? All I got to do is move the decimal place over one spot to the right. And that turns into milligrams per ml. So a 1% solution is equal to 10 milligrams per ml. So, sorry, mess that up. Scratch that out. 10 milligrams per ml. Okay? If I have a 0.25% solution, what does that turn into? You just move it one over to the right. It's 2.5 milligrams per ml. Again, it's an old nomenclature. It's an old way of demarcating the concentration of a substance, but we need it in practical forms, right? And that's how we do it. We convert it over by moving that decimal place one over. So as an example, why you might use this in the ER, say you're going to suture up a laceration, we want to make sure it's adequately numbed. The patient get a maximum of 5 milligrams per kilogram at one time. It's max dose of lidocaine they can receive before you worry about toxicity. We have a patient who's 24 kilograms. The question is, how much volume of lidocaine can I administer for that patient? Okay, so how do we figure that out? Well, the first thing we would do is take the 24 kilograms of the patient's weight, multiply by what? Yeah, I want to figure out what my max dose is essentially, right? So I'm going to take it 24 times. That's 5 milligrams per kilogram, and that equals how much? 120 milligrams. That's the max dose that that patient can get. Well, now my question is, well, how many mLs of that can a patient receive, right? Because again, you don't have a syringe titrated in milligrams, it's in mLs, right? So how much can I actually give? Well, I'll take that 120. I know it's a 1% solution, so by moving that decimal place 1 over to the right, I know it's 10 milligrams per ml, right? You see it right here at the top here. So how much can they get? So 120 milligrams divided by 10 milligrams per ml is what? 12 mLs, right? So that means that the patient, if it has especially a large laceration, I could use a total of 12 mLs before I'd have to worry about toxicity. You're not giving any more, okay? Makes sense. Everyone with me? So now you can do the math problems on the homework. So if you have any questions about that, that's fine. The thing with the homework is that there will be that rubric there, right? So work through that, look at that. There's an example prescription on there as well. There is 2 parts to the rubric. One is for inpatient orders, which we're not doing yet, right? So you can ignore the second half of that. We're only doing the outpatient orders, right? The actual prescription orders you would write for a patient who would fill it at a CVS or Walgreens or wherever, okay? So look through that. If you have any questions, let me know, but it should be pretty straightforward. Make sure you have all the stuff on the rubric that I'm looking for. If you don't, that's the easiest way for people to get points taken off. If your math is off by a little bit, that's no big deal. If you screw up the math big, then that'll take some points off. But the main thing is people forgetting things. Indications, people forgetting things like the route, things like that. You want to make sure you include all that. The last section I have is about more the logistics in terms of legal requirements for prescriptions. We'll get into that, but just make sure you follow the rubric. Yes, ma'am. It should be posted on the thing, is it not? If you look in the actual assignment itself, homework 4, do you see it? Is it just the assignment?
Yeah.
Okay, I will upload that to make sure you have the rubric, and that will make much more sense, won't it? Good thing. It is due next week, correct?
Yes, sir.
Fantastic. Okay, let me look to make sure see if you have any questions on here. I know math is hard, but practice it. It'll come easy to you eventually. Well, sometimes you may actually have to do this for adult patients too, right? So sometimes you may find you have to calculate a dose based off mg per kilo for an adult, right? Sometimes you do, but this is the majority of P's is what we do here. Yes. Any other questions? If not, I will see you guys next time.
Thank you.